now?
Yes, you're good to.
Thank you very much, Fairuz, for the kind introduction. And thank you, Santosh, for inviting me for this webinar. I actually learned a lot listening to all the lectures. Most of them were surgical topics, but it was quite interesting to listen to. Why is that I'm seeing only Fairuz here on the screen, not anybody else? Anyway, so Santosh asked me to speak few things what's happening in the chemotherapy front and radiation oncology front. So briefly on that, the chemotherapy, target therapy, and immunotherapy. What we do something different from the routine what others do is that what I'm trying to focus here. Most of them do not believe in chemotherapy for locally advanced orbital and orbital tumors. So we do that quite regularly. We have to analyze our results, but offhand, I can certainly say that our results have been quite gratifying, especially in advanced, locally advanced lacrimal gland carcinoma, where there is inoperable upfront or there is an intracranial extension. We do preoperative chemotherapy, 2 to 3 cycles, and then debulk it and then give post-op radiation, followed by further 3 cycles of chemotherapy. Similarly, meibomian gland carcinoma with the preauricular nodes inoperable upfront, but they have still uh, useful vision, and that kind of patients also we do chemotherapy first and then reassess and operate and followed by radiation and chemotherapy. So no exenteration, vision is intact, and this is how the patients respond to chemotherapy, and this is what the end result is. Neoadjuvant chemotherapy, surgery with exenteration, and then post-op radiation treatment. So similarly, sebaceous gland carcinoma with regional lymph nodes in these kind of patients also, we would do neoadjuvant chemotherapy. This patient had a preauricular lymph node, and this patient received chemotherapy followed by surgery and radiation treatment. We don't do unusual chemotherapy drugs, and these are the drugs which are already being used in hereditary malignancies, cisplatin and 5-fluorouracil are the common drugs. In some patients, we do platinum and paclitaxel as well, which is less toxic and easily tolerable to these patients. One of my colleague, Dr. Sachin, was mentioning of RMS. RMS is quite a common tumor in our scenario, and we do have, we just do biopsy and then followed up with chemotherapy and radiation wherever required. So we do see such kind of recurrent RMS. This is quite a challenging thing, which Santosh would agree. These kind of patients, which we would do salvage chemotherapy, and off late would like to let you know that we started using such kind of patients salvage chemotherapies. Look at the gratifying response to salvage chemotherapy, and we started using re-radiation because of the techniques that these days which are available to us. You look at the 100% dose to the tumor, and chiasm, optic nerve, and left eye are all quite easily spared, and this organs at risk are all completely spared. And this is the end result. And if you look at the drugs, what we use in the salvage chemotherapy are gemcitabine and docetaxel. These are the drugs off late we started using and having a gratifying results. Otherwise, these round cell tumors, we know the standard treatment are VAD, VAC, and ifosfamide, etoposide. But off late, after using gemcitabine and docetaxel, all these patients who have received earlier the standard chemotherapy have been responding quite well. This is after 1 year of follow-up. Orbital PNETs, unlike other areas of PNETs having sarcomas, although they look quite destructive and deceptive in such massive tumors, they respond quite gratifying results. What we have seen with the standard chemotherapy drugs of vincristine, adrimacin, cyclophosphamide, alternating with ifosfamide and etoposide, and we normally use this for 6 cycles. That means almost 12 doses of chemotherapy, which minimum of 1 year for younger age group or 9 months for 6 to 9 year old age group. So this is a child which had such a massive tumor with intracranial extension, did very well with post chemotherapy, radiation treatment, and see the gratifying result what you've seen with the CT scan here. So this is after 4 years later. She's doing quite well. Now it is after 9 years later. This is one of the rare tumors, fibromyxoid sarcoma. Although we know that this is not a chemosensitive tumor, on insistence by Santosh, we started chemotherapy in this child, and fortunately for the child, responded very well with ifosfamide and adrimacin, and that we continued and then added local radiation at a later date. This is the 39 grain, 13 fractions with stereotactic radiation. Very small child, 1 year old, now is 3 years old. Residual disease, but with no activity on the PET, is doing absolutely fine. So this is a child before and now, after a very active child at the age of 3 years, little bit of downward gauge, but this is doing absolutely fine with no activity in the tumor. And apart from these, there are no new drugs available as of now for the last 1 decade. Santosh wanted to stress on the new drugs. Unfortunately, no new chemotherapy drugs have come into the market. We're only juggling with the drugs which are available, and that's the way it is. Targeted therapy, you know what is targeted therapy? Is a molecular basis of oncogenesis is identified, and each cancer and a specific molecule is synthesized to block this pathway where there is derangement of the pathway. So there are the off late, if you look at the molecular treatment based on the molecular base, if you treat a cancer in a stage 4 lung cancer, which was never heard of, now it's almost 2 to 5 years survival, even in stage 4, if you treat a patient based on the molecular targets which are available on the tumor cell. So based on this, the target therapy is the way to go. Of late, see so many tumors. The first tumor which was cured, or CML. Now, as far as head and neck oncology is concerned, look at the melanoma is one of the areas where you use targeted therapy. But unfortunately, the BRAF mutation, which is seen in a cutaneous melanoma, is not often seen in uveal melanomas. So in a metastatic uveal melanoma, you hardly have any BRAF mutation seen, so we can't use vemurafenib. But as I mentioned, I was so interested to listen to Dr. Carol Shields. She was mentioning about using sunitinib as an adjuvant to prevent metastasis. But I doubt, I'm really gratifying results. That's what I've seen compared to the placebo. But sunitinib is a quite a nasty drug. It has got a lot of side effects. Using sunitinib for an year or two to prevent metastasis is a little practically difficult scenario. However, we know that there's no chemotherapy drugs or immunotherapy drugs which are to be very useful in metastatic uveal melanomas compared to the cutaneous melanomas. So immunotherapy is more hype than reality. As of now, the three main cancers which are immunotherapy is useful against anti-PD-1 and PD-1, carcinoma lung, renal cell carcinoma, and metastatic melanoma. Again, metastatic melanoma and uveal melanomas, see the success achieved by a single anti-CTLA-4 and anti-PD-L1 and PD-L1-2. The cutaneous melanomas have not been reciprocated in metastatic uveal melanomas. So that is unfortunate thing. Otherwise, this is the way to go forward. What the new immunotherapy drugs can be of help in metastatic melanomas. Few words about the what's happening new in the radiation department. We know we started with the conventional treatment. Now we have IMRT, rapid arc. I'll go briefly on those things. We know we moved from cobalt to linear accelerator, where you have high energy, high precision, and minimal side effects. So from 2D RT, we had a conformal radiation. We can shape the shape of the beam. This is called 3D conformal radiation. So what is actually happened, the real revolution happened is IMRT. IMRT is nothing but intensity of radiation is modulated within the field of radiation. You can deliver radiation from 0, 40, 60, 100, 180. So within the field of radiation, you can modulate the radiation dose of radiation delivered. For example, 180 to 200 centigrade can be modulated within the field of radiation delivered to the patient. So this is how the intensity modulation radiation helps. Even within the target, if you have a normal structure, that can be spayed, and you can get the shape of the radiation field and the dose to be delivered into the areas, into a complex target volumes. So now apart from that, now when the patient is lying down on the couch, we have an X-rays and a CT scan to make sure that the exit and entry beams are absolutely going through for where we planned in the computer room away from the treatment position. So now we got the couch, which is robotic movements, which moves in 6 to 12 directions. Make sure that the entry beam is exactly matching with the simulator, what we have done in another room. When we do it on the patient, exactly happening, that is called a simulator happening exactly on the patient when the treatment is going on. Again, they completely supervised. We have infrared cameras. Even fraction of a moment of the patient, the treatment automatically stops. That is called image-guided radiation treatment. So the entire treatment used to take earlier 12 to 15 minutes. Nowadays, it hardly takes 1.2 minutes. A high dose of radiation can be delivered dynamically while a patient is moving, the treatment goes on. Bilateral retinoblastoma, treatment delivered both the eyes in 1 minute, and that's how the distribution happens. The eyelids, cornea is completely spared, entire retina with 1 centimeter of the optic nerve is treated both sides simultaneously in a single go. This is the technology available these days. And see that this girl had to get married in 2 months' time. The rhabdomyosarcoma being treated, and there's no trace of the disease in an rhabdomyosarcoma or NHL. No skin changes seen, and no eyelashes lost. So there's another patient, young man, hemangioparasitoma, has been again had a marriage in 6 months' time, has been treated with external beam radiation treatment. So the conjunctival lymphoma, one of the speaker, Dr. Sachin, was mentioning, we do quite a lot of treatments like that. The conjunctival lymphoma being treated safely, and there's a complete responses with this kind of a treatment. So there's no evidence of treatment on the skin, on the eyelids or the eyelashes at the end of the treatment. This is another interesting case where the patient had intraocular NHL, which was treated in 2010. She had a recurrence in May 2013, again been treated in 2013, again had a recurrence in 2014, again treated with whole brain radiation. That is the beauty of the treatment with this new technology, what is available. Look at this lady, cheerful at the end of the treatment. On 5 years, she's been maintained with intraocular lymphomas being treated twice and thrice. So lacrimal gland carcinoma is a nasty tumor, as we all know. Unless you deliver 6,600 centigrade, the recurrence chances are very, very high. Most often we see these patients being treated elsewhere with 4,500 to 5,000 centigrade, and they invariably land up in recurrences. So we safely can deliver such high doses these tumors because of the technology and the expertise that we have these days. The tomotherapy is another gadget where it is an external beam radiation, where the rotation happens on the couch as well as on the head of the radiation machine. So you can imagine 360 degrees rotation of the radiation head and the couch moving from head to toe simultaneously. That means you can deliver the treatment from head to toe in one single go. For example, you have a craniospinal radiation for a CSF positive patient, it can be delivered in one single go. Or a patient with a brain tumor or a lung lesion with a liver metastasis can be treated in a one single go. Now, of late is a proton therapy. The greatest advantage of proton, as you all know, that this radiation will stop. There is an exit beam of the standard linear accelerator. That means at the exit, you have around 20 to 30% of the dose delivered at the entry. Whereas the proton has the greatest advantage of delivering the entire dose in the target, and after that, there is no radiation, absolutely zero. So that is a great advantage when you're treating pediatric tumors and ocular tumors like retinoblastoma and melanoma. So the stereotactic radiation is definitely helping us in a big way, because most of the tumors in the eye are less than 3 centimeters in size, which is precisely being treated without harming the rest of the structures in the brain or near the orbit. So stereotactically guided conformal radiation of the target in 1 to 2 sessions is called SRS. If you're treated in 5 to 20 treatments, it's called stereotactic radiotherapy. So you look at a lady, a 56-year-old lady with a choroidal metastatic disease, single dose of radiation, complete disappearance of the tumor. There's no trace of the disease here. And 2 years later, she developed another lesion in the opposite choroid. Same lady being treated with external beam radiation, stereotactic radiation with a complete response. Small lesions which are orbital apex meningioma, gallium dotanox scan positive lesion. You see here, see the DVH, dose volume histogram, 100% dose to the tumor, and the critical structures would get whatever the dose tolerance that this can taken up. Orbital apex schwannoma, again 18-year-old female, small lesion very close to the optic nerve exit of the optic nerve being treated with the radiation. Again, see the dose volume histogram, least dose possible and tolerable doses to the normal structures, and we get 99 to 100% control rate. Optic nerve gliomas, similarly stereotactic radiation. So the DVH here, and then the solitary plasmacytoma of the right orbit. This man is 72-year-old, 6 years before back we have treated, is absolutely normal with us. So solitary plasmacytoma without hurting his vision, without hurting retina, is being treated comfortably. A small metastatic lesion in the medial rectus muscle has been treated quite safely. Plaque brachytherapy, as you all know, the indications of plaque brachytherapy, and this is what we use here with us is a ruthenium, and the dosimetry is amazing. You get almost 98 to 100% near the plaque and hardly 5% a few millimeters away from it. Retinoblastoma before and after, and this ocular surface tumor and before and after. The regression rates are extremely good, quite gratifying. 97 in choroidal hemangiomas, OSSN 82, retinoblastoma, two-thirds of the patient, and almost 90 to 100% in uveal melanomas. Briefly about brachytherapy, which is interstitial. Some of the cases, as I was mentioning to you, lacrimal gland carcinomas, they are halfly treated or with 5000 centigrade. They have residual lesions like this, and we have wonderful team with Dr. Santosh. We do excision of that lesion, and after that we place the interstitial needles around the tumor bed. This is how the tubes are placed, and they are in place, and the sutures are done, and they are positioned in place, and then these are the tubes which come out, and they are connected to afterloading sources, and these sources are pumped into the areas where you want to deliver high dose of radiation. To remind you, these tumors have been treated by external beam radiation in the past elsewhere, and we have again delivered reasonable doses to control these tumors, and we have several such patients being done with interstitial brachytherapy. We need to keep very, very careful on the radiation sequelae. With this new and technology, the sequelae have been quite less, but because we are trying to do higher and higher doses, we need to be careful on that to reduce the dose to the retina and the optic nerve, which are the most sensitive structures in these areas. Now we are able to spare the lacrimal gland comfortably. If it is not a lacrimal gland tumor, rest of the orbit can be treated safely, reducing the dose of the lacrimal gland. The dryness can be spared much, much better. So as I said, we need to balance between the dose to be delivered to the target and simultaneously reducing the dose to the critical structures. Then you will be able to achieve the best. What we need is a team, and we need to have an excellent ophthalmologist along with an oncologist to work together, to work in tandem, when to intervene, when to give chemotherapy, when to do surgery, and what is the right time to add radiation to these patients. Then the results would definitely be optimal, and that's the way to go. Our attitude at the time of diagnosing a patient should be good. Our attitude should be curative, and then I'm sure ideas would come out, work as a team, and the results would definitely be much, much better. Thank you very much, Santosh. Thank you, the rest of the team, for listening to my lecture patiently.